Hello, I'm Maria Williams with the Collaborative on Health and the Environment. CHE enjoys bringing you the latest environmental health science through our partnership calls and webinars, science serves, publications, and social media. I would like to welcome everyone to today's CHE EDC Strategies Partnership Webinar, which is titled Prenatal Exposure to Phthalates Significantly Associated with Elevated Rate of Language Delay in Children. Our moderator today is Cheryl Patton, Director of the Commonweal Biomonitoring Resource Center. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available in the menu bar at the top of your window at any point during the presentations. After the presentations, our moderator will read out questions for our speaker to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 45 minutes and is being recorded for our call-in webinar archive. With that, I'll turn things over to you, Cheryl.
Thanks a lot, Maria. This is Cheryl Patton, and it gives me great pleasure to introduce today's speakers. Shanna Swan is an environmental and reproductive epidemiologist working as Professor of Environmental Medicine and Public Health at the Icahn School of Medicine in Mount Sinai, New York. Since 1998, Dr. Swan's program has been conducting multi-center pregnancy cohort studies to better understand how prenatal and early childhood exposure to stressors, including those chemicals commonly found in the environment, such as phthalates, bisphenol A, and analgesics, can impact the reproductive health and development of children, with an emphasis on sex differences in the impacts of these exposures. Shanna Swan's long been a leader in the field and a great pioneer in moving forward the issues concerning children's exposures at early ages. She's joined by Dr. Carl-Gustaf Bornehag, who's an environmental epidemiologist and professor in public health sciences at Karlstad University, Sweden, and adjunct professor at the Icahn School of Medicine in Mount Sinai, New York. Dr. Bornehag's research focuses on early life exposure for environmental factors such as endocrine disrupting chemicals, food and nutrition, lifestyles, genetics and epigenetics, among other things, and how such factors interact and impact on children's health and development. Their research investigated recently prenatal phthalate exposure in relation to language development at approximately 30 months of age. The research looked at 2 pregnancy cohorts, one in Sweden and one in the United States, and found that despite important differences in population and exposure levels, prenatal exposure to the same 2 phthalates was significantly associated with children's delay in language development. Today they're going to discuss their research and why their conclusions are strikingly important in terms of children's early exposures to language development and why that is important. So I invite you to go ahead, Dr. Bon. I think you're, excuse me for murdering the pronunciation of your name. I apologize for that. I think we begin with you today.
Thank you. It was perfect pronounced. We are going to talk about this paper published quite recently in JAMA Pediatrics. And we have been working together, Shanna Swan and I, on phthalates for quite a long time. And in recent days, more and more interest have been, I mean, the original focus for phthalates have been reproduction, but more and more interest have been into the area of neurodevelopment and these kind of exposures in early life. So here I just listed up some few papers dealing with the problem and where we today know that language disorders in early life seems to be important for neurodevelopment in general and also neuropsychiatric problems later on. The first paper here by Nelson is a paper, is a report from the American Academy of Pediatrics, where the starting point was that it's known that speech and language delay is important for school children, and in this paper, they describe factors that are important to understand, that are determinants for language delay in early life. And even the second paper here is also about these late talking toddlers, as they call them, where they have gone through the literature and identified characters to understand more about this, because it's so important. The two last references here is by Carmena Miniscalco from Sweden. And in the first paper here, she looked on neurodevelopment and language delay at 30 months of age. And then she looked on neuropsychiatric disorders at age 6 to 7 years. And she could see that there was a strong association. If they had language problem in early life, they were at risk to have neuropsychiatric disorders later on. And in the second paper here, she could see that her language delay at 30 months of age or 2.5 years was, when they looked at the same children at six years of age, they had a high risk to still have these language skill problems. So there is quite a lot of information out there that language delay in early life is a warning signal that should be taken seriously. Miniscalco, the two last here, is also, it's her that developed the language tool we have used in this study. So I will come back to that. In the 2006 paper, it's described what this is. And this is quite a simple, this is in Sweden today, a clinical tool. So this is what we have used is just a simple question from a nurse to the family. How many words can your child say? And then they respond in 3 categories, less than 25 words, 25 to 50 words, and more than 50 words. There are more information and there are more questions in this clinical tool, but we, in this case, have only used that, and that is of power reason, because many of the questions there are very seldom found to be relevant. But we have used this one. In TIDES then, the American study where we have data from in this paper, the SELMA is the Swedish study and the TIDES is the American study. And there we made a translation of the Swedish tool. And it was then mailed to the mothers, not at exactly the same age. In SELMA, the kids were 30 months of age when they visit the clinics. And in TIDES, they got the mail and responded on that questionnaire when they were around 27 months. And we have defined the language delay as the kids that were using less than 50 words. And we did that in both the studies. So Shanna will now talk about the compounds we have been focused on.
Hi, Cheryl, I want to thank you for your nice introduction, and I'm glad to be having a chance to talk about our study on this call. As Carl said, yeah, let's just keep that for a minute. We are looking at phthalates, which is a common exposure. 100% of the SELMA mothers were exposed to all the metabolites that we looked at, and almost 100%, as you'll see, for in TIDES. So these phthalates are common exposures in pregnancy. We're exposed to them through all the possible routes, so ingestion, dermal exposure, and inhalation. Next slide. Carl, are you going to advance it? Or thanks. So this just shows the major phthalates and their metabolites that we're looking at. Of course, the metabolites are what we measure in the urine, measure the concentration. And the 3 that are bolded on this slide, which is diethyl hexylphthalate, dibutyl phthalate, and butyl benzyl phthalate, are those that have been are most concerning, particularly because of their anti-androgenic action. We also have findings on diethyl phthalate, which is not considered to be a potent hormone disruptor So that's a little bit surprising. Next slide. And as I said, we have metabolites in SELMA at 100%. All the metabolites are 100%, but in the United States, they're lower. And we'll show you some other data on that also. And in particular, one of the metabolites, the primary, well, the first metabolite of DEHP, that very large phthalate, was not as common as the others in our population. If we compare the phthalates in SELMA and TIDES, you see a quite remarkable difference between the two populations. And in SELMA, the levels of monobutyl phthalate, for example, and benzyl butyl phthalate were more than 5 times as great. And part of that is because these products are used in PVC wall covering and floor covering, which we don't do in the United States. But this makes the interpretation of our data interesting and a little complicated. And also to point out that in the United States, where we have the measure, the things measured in the urine analyzed at the CDC, we have 2 metabolites of dibutyl phthalate. And whereas in Sweden, those were combined. So the tables will look a little bit different. You'll see an extra row for the US study because we have these 2 metabolites of dibutyl phthalate. Carl?
Can you hear me? Yes.
Yes.
So here you will see that the layout of the SELMA study. The name of the study, SELMA, is quite important in these days because this study is conducted in the county of Värmland in Sweden, and that is where Selma Lagerlöf, the first female Nobel Prize winner, was born and lived almost her own life. We have another explanation for the acronym, but of course it's about Selma. She's very big here. So the SELMA study then is about following families from early pregnancy. We took samples from the first trimester of the mothers, serum and blood and other things. And in this case, we were interested in these phthalates that we have talked about. And we measured them as metabolites in more than 2,300 mothers. And then we followed these families, and for this purpose in this paper, we used the data for language delay, as I explained earlier, at 2.5 years of age. And we got data from 1,100 of these kids from the clinics. And the simple question here was, how many words do you use? After that, when the kids were 7 years, we made psychological tests of them, and we have data there for around 1,000 kids tested by WISC, and that is about cognition, behavior, motor, and things like that. That kind of data is not included in this paper, but we have the data now, and I will mention some few things here later on. But now we focus on, was there any association between the exposure in early pregnancy and language delay at the age of 30 months? So this picture is then explaining what associations we did find. To the left here, you can see the compounds, the monoesters of these 4 different diesters measured in the urine of the mother. And then you see associations expressed as odds ratios here. And the red marked area here is including 2 compounds, the MBP coming from DBP and the MBZP coming from BBZP. And you can see here that the association were significant, both in crude and adjusted values. So we had, by doubling the exposure in the mother's urine, the risk for a kid having language delay was increased by roughly 20 to 30%, depending on the model. We were also very interested in to see if there were different associations between prenatal exposure for these phthalates and language delay in girls and boys. We did see some indications for that, but a problem here is that we will show that later, that language delay is much more frequent found in boys than in girls. So to look only on girls, it's a problem. So in the SELMA study, in the Swedish study, we could see an association for mainly 2 compounds. We did find also association for the MEP, which, as Shanna told earlier, not seen as an anti-androgenic compound, but we did see, but a much weaker association as we did see for these MBP and MBZP. And in the SELMA study, that study is based on more than 900 kids. And here we had then the statistical power to divide the exposure into quartiles. And here you can see to the left, the MBZP, and to the right, the MBP in quartiles. And we used the first quartile, the lower, the 25% of the mothers with the lowest exposure as a referent. And then you can see that there, for both these compounds, there were an indications for a dose-response relationship. So the kids born in the upper quartile, the 25% highest exposure, they had almost a double risk for language delay when compared with the first quartile. And below here, you can see how we adjusted the models. We adjusted for the urine concentration by creatinine in SELMA. We adjusted for sex, premature birth, the mother's education, and smoking, and mother's weight. And this is quite similar to the way we adjusted in the American data, but Shanna will talk more about that in the TIDE study.
So in the TIDE study, the Infant Development and Environment Study, we also use this language delay question. Just a couple of words about TIDES. So TIDES is a pregnancy and child cohort study being conducted in 4 cities in the United States. We enrolled women in 2010, and they had to be in the first trimester. We enrolled 869 women. And then we followed them at birth. We had 758 births. And then we followed them subsequently. They are now 6 years of age. They're getting their 6-year visit. And at that visit, by the way, they are also having a WISC, which we'll look at just as Carl did in the SELMA study. So, the Data Cording Center is in Mount Sinai, where I am. Next slide. So in TIDES, we collected urine in each trimester. We're interested in timing of exposure, so that was useful for that. We got blood in the first trimester, and we got questionnaire data throughout the pregnancy, once in each trimester. We asked about possible sources of phthalates, including diet, personal care products, their occupation, and then we added other exposures, non-biomarker based, such as stress and medication use. And then, as I mentioned, we had the interim questionnaire. So the interim questionnaire was sent to the mothers when the children were, we targeted the 30 months, but we didn't make it. And the average was actually 37 months, a little old for that questionnaire, but there it was. And we also only got this data on about half of our children, 370. So this is much less powerful than the SELMA study. But we're able to include for those 370 the Swedish questions on language development. And so here are our results. And we use the same format as you've seen for SELMA. As before, the compounds are on the left. We have the crude and adjusted odds ratios and confidence intervals. We also included an interaction term because we wanted to see was the difference between boys and girls significantly different with that associations. And as in SELMA, we didn't see a significant interaction. However, one of the goals of our study, TIDES, is to look at sex-specific differences in associations. So we also looked at a stratified analysis where we looked at boys only and girls only. And so just to go back to the results for the entire population, as in SELMA, we saw significant associations in the crude models for dibutyl phthalate metabolites, we have 2 of them, and also for benzyl butyl phthalate metabolite. However, once we adjusted for covariates, we lost the statistical significance, probably because we have only 370 children. But it's interesting that the point estimates are very similar to those in SELMA. And also for MEP, we didn't see a significant association, so that was a little bit stronger in SELMA. So there are a couple of differences I want to point out between the populations. Of course, the sample size is very different, but also SELMA is all Caucasian. Those are all Swedes, native-born Swedes. And in TIDES, we have many ethnicities and races, so that we have 74% of our population is Caucasian non-Hispanic compared to 100% in SELMA. The premature birth rate, and prematurity was a risk factor for language delay, by the way. Premature birth is more than twice as prevalent in the United States as in Sweden, for reasons that we can, another study, right? We also had a slightly higher, more educated population. Smoking was very similar between the 2 populations. But what was amazing was that despite all these differences, the rates of language delay, both overall, that is less than 50 words, 10% exactly in both studies, we thought we had made a mistake. We had to recalculate it because it couldn't be. And then under 25 words was exactly the same. And what I want to point out here is the rate of language delay in boys and girls is very different. So of the girls, in SELMA and TIDES, if you put those together, about 7% of girls have language delay and about 12% of boys have language delay, a little over 12%, 12 to 13%. So it's almost twice as great language delay in boys as in girls, which is why we have more power for the boys. CG?
Yes, so putting our findings in a scientific context, we can, there are literature out there that have been looking on prenatal phthalate exposure and neurodevelopment in children, but neurodevelopment is a very broad area. But if we then go into more cognitive tests, there are some data on that. One difference, I would say, that most of the studies available today have measured the exposure late in pregnancy, in the 3rd trimester, while we, both in SELMA and TIDES, have used the 1st trimester. We don't really know the importance of that, but we are, not so very many others have done that. Of course, the tools and the instruments for assessing language delay can vary between different studies, but several of the studies we have found have used the VISC, have used language delay as one of the cognitive outcomes. The 10 studies we could find have, in general, a negative association. So prenatal exposure is associated to language delay later on in life for the kids. And the compounds that have been shown in several studies are, I mean, DBP and BBZP, which was the 2 we found in our study, have been found. DBP have been found in 5 studies, including ours, and BBZP in 2 other studies. But there is also data showing that DEHP can be associated to language delay later on. And DEP have been seen in 3 studies. So in conclusion, I think our findings is concordance with what have been shown in other studies, even if there are differences in layout, design, and ways of measuring in the different studies. Since we did this study, as I said before, we have got result for cognition of the kids. And here is a full-scale IQ measured by the VISC when the kids in SELMA are 7 years of age. And as you can see, this is a standardized scale, so the mean value should be around 100. And you can see in this picture that this is 917 kids, and the distribution seems pretty good. And you can see that the mean value is almost perfect on 100. So this is trustful data. This is tests made by psychologists, so we can really trust them. And one question is then, of course, is there any association between having language delay at age 30 months and full-scale IQ for 3-4 years later? And we expected to find an association, but I didn't expect to find such a strong association. This is very preliminary data, but I want to show it because the question is, how can you rely on just asking in how many words they are using? So here you can see the language delay on the x-axis, and the kids with no language delay, they had a full-scale IQ of around 100, which they should have. But those kids with a language delay had almost 10 units lower score in the IQ scale, and this difference is extremely significant. So, and this is really strong data. We just made a model for this, so we then adjusted for the mother's IQ, because now we have tested even the mothers. We included in the model factors that we know are of importance for children's language delay. So the mother's education, her smoking habits, her body weight, and we also included prematurity in this model. And when we do that, we can see that a kid with a language delay at the age of 30 months had a 6.6 unit lower score when they were around 7 in full-scale IQ. So now we are, of course, interested to follow these kids further on and really look on the exposure and the relation to cognitive outcomes later in life. And Shanna will now talk about the compounds that we found.
So I just wanted to say a few words about these two phthalates and how they're regulated, because now we're very concerned about this exposure to pregnant women because we're seeing a lot of impacts. And so just to remind us, I think everybody on the call probably knows already that DBP is a plasticizer. It's in personal care products and building materials, and maybe not so well known, it's both a developmental and a reproductive toxicant on California's Prop 65 list. Benzoyl phthalate is also a plasticizer in polyvinyl chloride, and it's a developmental toxicant on California's Prop 65 list. And both of these are permanently banned in children's toys and child care products, both in Europe and the US. In Europe, they have a higher standard. They have the standard of REACH, and both of these compounds are deemed substances of very high concern in REACH, and they cannot be used in Europe since 2015 without permission. And I just want to mention that Silent Spring Institute provided this information on regulation. So Carl is going to summarize.
Yes, so the question with this study was to examine if the exposure for phthalates in early pregnancy could be associated to language development in children when they were around 30 to 37 months of age. And we did this in 2 studies, one in Sweden in a typically rural area, and one in the US covering 4 sites in the US, both in the West and East Coast. And what we did find was that 2 of these compounds of these phthalates, the DBP and the BBZP, the metabolites of these compounds in the mother's urine in first trimester, was associated to language delay in both the studies. And we even found that the prevalence of language delay was similar in the both studies. So this is, of course, what is the interpretation of this, and there are of course several things here we don't know. We don't know very much about the mechanism behind this, and even we need also more epi-data, of course, to better understand, is there really, one of the things that we couldn't explain here was if there was a real difference between girls and boys. The only thing we can see is that boys suffer more from language delay than girls. But in both the studies we are now, in SELMA, we now have the data from the age of 7, as I showed you, from real psychological tests. And in TIDES, these data are now collected. So we hopefully quite soon can analyze prenatal exposures and the relation to the cognitive functions at age 7. You may have something to add there, Shanna?
No, I think that was a great summary. I think we should turn to questions.
Yes.
Okay, thank you very much for that excellent presentation. We have a few questions coming in, but I just wanted to ask quickly, these substances of concern are regulated one way or another in both the United States and Europe, and yet it seems like these exposures are continuing. So I'm wondering what your sense of that is. Are they still being used, or is this old products being used? As, for example, vinyl flooring, old vinyl flooring still outgassing these chemicals? Do you have a sense of what the sources of exposures are given the regulations? Are they just simply not being implemented?
CJ, you want to take that one?
Yeah, I think it's a very good question, because there is a big difference between the US data and the Swedish data. Sweden is one of the very few countries in the world that are using vinyl flooring in homes. Mm-hmm. I think vinyl flooring is used in school and daycare centers and hospitals and things like that around the globe, but I don't think there is any country that are using so much of PVC flooring in kitchens and in sleeping rooms as in Sweden. And we know for sure, we have other data today showing that exactly these two compounds we are talking about, DBP and BBZP, is related to, so having a PVC flooring material, then you have higher levels in your urine if you are living in that home. It's not explaining the total uptake, of course, but the US situation is not similar here. Mm-hmm. Mm-hmm.
Okay, thank you for that answer.
And that was also shown in the slide Shanna showed earlier, that we are higher in levels for these compounds.
Mm-hmm. And so in Sweden, what's been the reaction to the publication of this study? Is there more concern now about changing regulations?
Well, there is a big question of this today in Sweden. The industry is claiming that they don't use these compounds any longer, which may be right. But the problem is that the PVC flooring material can be there for 35 years. So even if you replace these compounds in new products, you will go on exposing more than one generation of people, because until the next time you change your flooring material. So this is quite a big discussion in recent years, not only because of this paper, but because of other things.
I just like to add that is probably one reason why there's such a discrepancy between the two countries in terms of their exposure levels, because you have in Sweden the legacy of these, of these chemicals that, as you say, will stick around for a long time, whereas the U.S. use is much more transient. So it can be in food, it can be in personal care products and so on, but these are not going to stick around. So I think that's, you know, the fact that the use has been going down is reflected in the lower levels in the United States, and it's not reflected in Sweden because it occurs in different ways.
Yes, and thank you for that answer. But even though the exposure levels are lower, it looks like there's still 10% of the children in both studies are
Right.
Experiencing the same outcomes, right? So,
Right.
yeah, so it looks like at even lower levels, these things happen.
Yes.
Yeah, and I think that is incredibly important to know.
Yeah.
Let's move now to some questions here from Lubna Ahmed. When conveying this information, these findings to a lay audience, and particularly for those living in low-income communities with little access to fresh foods and organics or all natural products, what do you suggest the messaging should be in terms of decreasing exposures to phthalates?
Oh boy, difficult.
Yeah.
Very good question, very difficult to answer. I don't think, we don't know to the extent, we know, for example, that DEHP is very common in food and important in, you know, tied to whether it's organic, but I'm not sure that's true for these two phthalates. Here, I would be more concerned about personal care products and cleaning products and so on. And I always recommend that people go to Environmental Working Group and check out their products. And it's a great resource, and that's something that you can do even in less affluent communities. You can choose a less toxic choice by making, you know, by going to that website and looking at the selections.
Okay, thank you. And whether in the TIDE study or other studies, has there been any analysis done on phthalate exposure broken down by race? And if so, what have been the findings?
So Tracy Woodruff and Amy Zoda did a very nice analysis of NHANES data by race. And there are a number of exposures that are more prevalent, phthalates that are more prevalent in lower SES and non-Caucasian populations, but not all. And as I refer you to their papers because I don't have it in front of me, but my recollection is that a number of personal care products were, phthalates in personal care products tended to be higher in the Caucasian and more affluent populations.
Mm-hmm. Okay, thank you for that. And just as you go forward in this study, will you be looking at other phthalates? Because it's my sense as these phthalates may be regulated and removed from products, there will be substitute phthalates that perhaps have not yet been biomonitored for or identified.
We can only look at the phthalates that are measured, for example, by the Centers for Disease Control, where we send our samples, or at the lab that's Carl uses. So we're a little bit at the mercy of what the lab actually brings online, but they are switching to start measuring the more current use pesticides. Excuse me, phthalates, pesticides too bad, phthalates. So they're keeping up as best they can, but there's a moving target. So this study, these exposures were for us, 2010, 2011, and there have been a lot of changes since then. Just parenthetically, we had another study 10 years prior to that, and there the levels, say, of DHP were twice as high. So there definitely has been the substitution.
Yeah.
The bad news is, of course, that the substitutes don't tend to be any safer.
Yes, unfortunately, we find that true when regulation happens. Well, I think, let's see, can you talk about the use of phthalates in healthcare in light of your results? Are there regulations for this in Sweden, for example?
Yes, first of all, if we, with healthcare means tubes and treatment equipments for diseased people, then we talk about completely different exposure levels. You can be extremely high exposed, and since several of these compounds have been banned in Sweden, today we have, I would say, much better material for these kind of equipments, and it's not only based on regulation, because the healthcare system have been quite concerned about this. And I mean, there is also data out there showing that the exposure, the urinary levels can be 100 times higher if you are exposed to this equipment. So I would say that during the last 10 years, that situation has been much improved in Sweden.
Okay, thank you for that answer. I think we've reached the limit for our conversation and our question and answer period. So I want to thank you both for this presentation, and it's just so incredibly important what your findings are in terms of how we need to take care, much better care of our young women and our children. And Sean, of course, we've all been following your research for many years, and you've always been a pioneer in all this work. And I just always wanted to thank you for all the work you've done, and also for you too, Carl Bornehag. This is just incredibly compelling, important stuff. So I look forward to another webinar when you get more data about the cognitive impact at age 7, and perhaps we can schedule another webinar for that, because I think it's important to keep getting this information out to our health affected groups and our constituencies and our regulators here in the United States and Sweden, so we can get better controls and better awareness of what's happening. So thank you again. And Maria, do you want to formally close this call?
Yes, thank you very much, Cheryl. We are approaching the end of today's webinar. A video recording will be available on the CHE website soon, and tomorrow you will receive an email containing a link to the recording. CHE's next webinar from the CHE EDC Strategies Partnership will take place on Wednesday, January 16th, and will feature Dr. Sue Fenton, who will speak about the National Toxicology Program's work to evaluate and provide data on a large number of PFAS chemicals. Details will be available on our website soon. Please visit healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events and more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website. Additionally, if you appreciate these CHE partnership webinars, bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers once more for taking the time to present today, and Charles for excellent moderation. Thank you so much for joining us, and have a great day.